All right, so this talk is about delirium. And as you can see, I'm learning those. Um, First thing about delirium is to know actually how often does it happen, okay? Uh, you'll see from the slides that I'll show you later, it's actually very varied. You have up maybe 1 to 2% for the community dwelling, healthier patients, um, and then it goes up to 80% in the ICU. In fact, in some slides, you'll see that it even puts 100% in one study. So it's a very varied uh, uh, occurrence and prevalence. However, it's a very common problem. Now, after reading all the stats, I really have like a simple way to look at it, which is 60-70. If on average 60% of our patients that we see, the elderly, the frail, have it, and 70% of the cases are not diagnosed. So just keep that in mind. So even though it's very high prevalence, 70% of the cases are not diagnosed. And I don't mean us provide like nurses, nurse practitioners and doctors only. Believe it or not, nurses are missing it too. I was surprised because all the protocols are around nursing assessments. So we'll talk about that later. Um, and of course, it's preventable. 50% of the cases are actually preventable. So you have a high prevalence disease or syndrome, and it's missed a lot, and it's preventable. It's like a minefield. It's really something that there's a high potential for doing something positive with. So if delirium patients are confused, and this is during residency, the first thing I learned in geriatrics is like, how can you tell if a confused patient has dementia or they have delirium? They both are confused. How would I know? And this, walk through this and see if it makes sense to you. But basically, if a confused patient is suddenly confused, not just, and I don't mean by sudden like the night shift comes to start their shift and they find them confused and they call us. That's not suddenly confused. If a patient's family never visited in the evening and they come in and bring the nurse to the patient room and say, look, mom is really confused today. I've never seen her like this. We know better. So really sudden means sudden, like not just sundowning. Then it's delirium, okay? Because for dementia patients, nothing is sudden when it comes to confusion. It takes months to years, very progressive. Now, I put an asterisk there because there's an exception to every rule, and I'm going to tell you that exception. But generally speaking, when you look at delirium, it is sudden change in cognition. When you look at dementia, it's a long-term progressive, something that happened a long time ago. And if people tell you otherwise, you can kind of dig deeper and find out that it's not sudden. For example, we can say, well, what's the last time mom drove, for example? They'll say, oh, she quit driving 5 years ago. And you say, why? And so you ask about those things, like who manages the medication? Is mom taking her own meds? No. Why not? And when you get the answer to the why nots, you'll find out that the confusion didn't start suddenly. So delirium patients are also agitated. But again, suddenly agitated. And if they were agitated to begin with and they were not a pleasant demented patient, they're much more agitated than their normal routine. So that, again, the sudden shift is the delirium. The progressive steady thing is the dementia. With dementia patients, we usually have triggers. Now, granted, we don't always know them. So if somebody says, okay, somebody is always agitated, but really we don't know why. That's a good description, that there's probably a reason, but we just don't know it. And that means we keep looking until we do. And then there's a pattern. And again, we may not know it because we only see them for one shift, or I see them for one visit. But if we talk to each other and family, we probably can ascertain a pattern. It's very rare for somebody not to have triggers and not to have a pattern and be agitated in dementia. Because with dementia, there's very few ways of communication left for the patients and residents, so we consider agitation as a way of communicating something. Displeasure with something, agitation because of something medically or socially or environmentally. The other thing is that delirium patients' symptoms fluctuate. And believe it or not, they would fluctuate within like the hour, within the day. So you have somebody who's, the family comes in the morning, they're great. The next family members come in 2 hours later, they're not. You come visit them, the doctor goes in to evaluate for agitation, they're doing perfect. The doctor leaves to do his note, you go back in, they're not. So that fluctuation, that's delirium, okay? Dementia patients have a steady, predictable confusion, agitation, lack of concentration, etc. And then last but not least, delirium patients have something medically going on that's new, that's causing the delirium. Dementia patients don't need to have a UTI to be confused, to be agitated, right? Delirium patients have a cause, and that's the detective work. So the first thing we do with the delirium patient is ask over and over again, what could it be? What's the cause? And a lot of times it's multifactorial, because in geriatrics, unlike pediatrics, we oftentimes don't have a unifying diagnosis. We have one thing that's caused by 3 or 4 things, and then you have 3 or 4 comorbidities. For those of you who are didactic, this is the DSM-5 criteria for delirium. So you have the disturbance in attention and cognition, okay, and the short period of time that it develops compared to dementia, so hours to days, and there is a cause. There's something you can find on physical exam, labs, workup. So remember we said 70% of delirium is missed? Now, out of the deliriums we detect, a lot of times we're missing this type of delirium even more, okay? And that's the hypoactive delirium. Now, I'll mention a different slide a little bit later, but any of you remember the word psychomotor retardation? Okay? Now, basically, that's what this implies. So now we say hyperactive delirium. So the patients are actually so withdrawn, so inactive, speech is slowed, they're not doing much, they're basically very easy to take care of. But they have delirium because guess what? That's a change for them. And that happens suddenly, okay? And there's a cause for it. So it meets the criteria for delirium. They're just not yelling, thrashing, restless, swearing at you. But they still have delirium. So most of the time people would confuse them, especially in the hospital where they don't know their baseline, or post-acute care. We would say, they're either depressed or demented, the way they're acting. So watch for the sudden. So again, look for sudden if you're looking for delirium. Nobody gets depressed right that minute to that extent. The irony is, the quieter they are, the higher mortality. So the quieter ones die more. They're sicker. And they have more comorbidities. You can imagine if somebody's barely leaving their bed, they're going to have wound issues, okay, skin issues. So this is from the British Medical Journal that I found. Actually, it's a nice diagram. It separates the two, hyperactive delirium. And again, it's not very complicated, it's very educational. So you have the restlessness and agitation and the hyperactive, the increased motor activity, loss of control, so it's not like directed activities. They lose control of what they're doing, they're just impulsive about it. And they're less restless and wandering. Now again, this sounds like a lot of our dementia patients, but what's the difference? It developed suddenly. okay? And it's reversible. The hypoactive delirium, you have everything decreased from activities to speech to awareness of their surroundings, withdrawal. There's also a mixed type. If within 24 hours you can see both, then you have mixed. So if somebody wakes up till 10 a.m., they're withdrawn, they're not talking, and suddenly they're up and agitated, okay, then consider it's a mixed. That's the DSM criteria, again, through the British Medical Journal. I put this one because this is an article that goes over the incidence, and I put it so you can see the title and the date, 2015, and this is the prevalence. So you could see over here, you see the prevalence for each setting. So if you look at cardiac surgery and anesthesia, hip fractures, ICU, look at the ICU, 36 to 100%. Now I don't like that wide range because that means the data is so all over the place. And that tells you how difficult this disease process is to detect and diagnose.
And that's talking about upper.
Both. So again, I'm showing you this because look at the age group here. So 14% of patients over 85 develop delirium regardless of the setting when they're ill. And then again, look at 87% when they're in intensive care. So the intensive care patients get it more because of obvious reasons. I mean, number one, they're sicker. Number two, they're not allowed to be mobile. Number three, they have things like catheters, which is a risk factor. And so that immobility, restraints, the acute illnesses, the catheters, the infections, they all add to it. There's also one more thing that caught my eye in just looking at the research is 3 or more medication changes for any patient is a risk factor by itself. So if somebody comes to the hospital and they have to be on 2 antibiotics and they had to be on blood pressure medication, the insulin was changed, that's already puts them in delirium category. But remember, it's preventable. So what we're looking for is learning what causes it so we can deal with it, both before it happens and after it happens. I mentioned these ancient words, so psychomotor agitation, psychomotor retardation. Now think hyperactive delirium, hyperactive delirium. Now, delirium, of course, can be with or without dementia. The thing to remember is, if you have dementia, it's a risk factor for delirium. So if you have a dementia patient going to the hospital with pneumonia, they already are predisposed to having delirium because they have dementia. The flip side of it is, when a person develops delirium for the very first time, sometimes it's actually a hallmark for them, like they're going to develop dementia anytime now. And it's almost like they're close to the edge, and the delirium shows that they're very close, and they get pushed over. After 2 months, they go back to baseline, but they lose a little. I always think of what happened to President Reagan, for example. When he was shot, he did very well. And I actually looked up all the news articles around the time he was shot to see if there was any mention of delirium. And of course, the paper said, he's in his 80s, and it's like, oh, he got shot, he went out of surgery, he went back to his duties today. So I'm taking that with a grain of salt, but I'm guessing if he developed delirium post-op, and Nancy Reagan was helping out a little bit, then that shows that's when he started to develop his dementia that was later diagnosed. I only mention that not because it's a fact, but just to get you thinking that that's how the relationship goes between delirium and dementia. The other thing is perception disturbances. Now this is a fancy word of saying, people can hallucinate, basically, okay? They can also have other psychotic symptoms like delusions, so not just perception of visual, but perception of reality. Both dementia patients and delirium patients can have it. Again, what's the difference? Which one happens rapidly and Delirium. Which one is reversible?
Delirium.
Delirium. Shorter period of time. So if we treat, now this is a controversial issue. If you read in the books or even the board exam preparation for both internal medicine and geriatrics, they write you a case of delirium and they say, what can we treat them with out of these medications? Let's say Ativan, Haldol, Trazodone, and Ambien. And the answer is Haldol in the board exam, still, okay? Because the old data still has that as your only treatment. Now the treatment, like you have something, you treat in it. I don't believe we need to treat delirium. I think we can treat the symptom of hallucination because it's very distressing for the patient, if it is distressing. But you don't treat because they have delirium, they don't get the Haldol. If they have hallucination that they think the nurse is about to kill them and they see the knife, then that's disturbing. You got to treat that. And how do you treat psychosis? With antipsychotics. That's an exception to the rule in both dementia patient and delirium. However, you put a time limit with delirium because you can't treat it for 6 months when you expect that delirium patient to resolve in 2 months. So at the most, we should be treating for 2 months. All right. Screening tools. Now, thing to remember, this from the NIH, basically, that's what they recommend. But the CAM, the confusion assessment method, both the standard and the ICU specific one. The mini-COG is not here, but these are useful tools for screening. Okay, they're not required for you to make the diagnosis. The DSM criteria guides you. So for nursing staff, they can use one of these tools like we use the Braden scale. We use a scale to detect issues we would otherwise not be able to detect. And the CAM is actually a pretty good one. It doesn't show you the severity very well and progression. Although there are ways to indicate severity, but then there's severity and there's severity. It's very subjective. And because of the fluctuation, they could be severe in the morning and very not severe in the afternoon. So for what it's worth, these are the tools. If they're on PCC, you can use them.
How about that?
Yeah. I didn't try that one.
There you go. And that's the same stuff. This is a link in your slides, which you will have online. If you want to actually look at the CAM training, the confusion assessment. The HELP program is something I wanted to mention. This is the Hospital Elder Life program. It was developed at Yale, and now the Dr. Inouye, who moved from Yale now to Harvard. I hate that, but she did. And she did actually a lot of the new data on delirium comes from her studies. Okay, and she developed this to prevent delirium. Remember, we said delirium is preventable. So she basically looked at all the risk factors associated with delirium, falls, high readmissions, all the elder issues that are preventable, including delirium. And they said, okay, how do we prevent it? We can address each individual risk factor. And it was validated. And the Maine Medical Center happens to be using it. They had used this for at least 7 years now. And it's successful. So this is a quick look of the risk factors and the interventions. So the cognition impairment is a reality orientation. Now, some of you would go to a room and see a whiteboard. I guarantee you we'll improve on that, because I can tell you that that's not working half the time, because they're laying down on their back. They have the O sign, which is, and they're looking at the ceiling, but there's a board over there saying your nurse is Sally today, and you are a Maine Med. So I mean, most of you who went to a dentist, sometimes you see the artwork is on the ceiling. That's what would work for our dementia patients in the ICU, obviously. Now, it would be nice if they had a monitor over there that's controlled from a laptop that you could change the information as you go, maybe put some children pictures, my cat's pictures, something like that. And that would be like the next step. The vision and hearing impairment. Now, many of you in our facilities would go and get an amplifier for somebody who can't hear, and you see what big of a difference it makes. So the hearing is a big one. The vision, it's very hard to fix unless they have their own glasses, in which case you've got to make sure that we get them, and I think most of our facilities are pretty good about this. These are the first things they do, is to make sure that they have their glasses and they don't lose them and they're clean. And if they're cloudy, just clean them and see what happens. Immobilization. So remember we said the ICU has more, they're more immobilized. So what they do is that they bring in volunteers so that they mobilize faster. On day one, on day two, they don't leave them in bed while they're working up their cardiac, functions and stress tests and catheterization. The psychoactive medication, that's important. So we obviously, psychoactive means anything that affects the brain. Okay, remember, including Haldol, by the way. So technically, if you give a delirium patient Haldol, based on the larger principle, it's the wrong medication, unless they're hallucinating. And if they are, there's better drugs. Dehydration is a big one. Now, how many people do you see that are sick, they're not eating at a great level? Okay, they don't. So we used to put IV in everybody in the hospital to just keep vein open. It turns out it actually is helpful. Even if you're given 200 cc's a day, 500 cc's a day, it ends up being helpful for somebody who's missing a couple of meals and they're sick and they're not drinking very well. So it's good for early recognition, especially in the hospital setting, because that's an easy fix. Sleep deprivation is a big one in all settings. So remember, we're not giving hypnotics based on this risk factor, right? But yet they have sleep deprivation. So the same people have a problem because they're not sleeping well. They develop delirium, okay? Or they're restless at night and they fall. And that's one of the things that you could fix. And there are things people would always come to me when it's in a crisis when I say, well, let's look at all the aspects. And it's almost like I'm disappointing them because none of those things that I'm saying will have an immediate effect, okay? But the fact is, you have to look at all aspects, because if it's not going to work now in 2 hours and 5 hours, it's going to help them the next day at least. So noise reduction, sleep enhancement program, keep in mind that includes no napping during the day. Now that's very hard for nurses to do, because imagine you're kind of working against yourself. If somebody is napping nicely while you're passing meds at 2 in the afternoon, and your job is to actually say, excuse me, is there anything you want to do so that you can sleep tonight? Or take them out of that Jerry chair. So it's counterintuitive, but it is really what's needed. And imagine when people are in bed for 1 day in the hospital, they need 3 days of rehab. When their sleep cycle reversed, when they nap during the day, well, you can imagine how many days it would take for that cycle to go back. So it's easier to prevent it. Once it's reversed, it's going to take you many more days. Now, I myself think the diet has something to do with it too. A lot of our residents would be up at 10 o'clock, 11 o'clock, midnight, and they get sugar all the time. And they're on a sugar high during the morning. So, I've been using, peanut butter crackers, other things, anything that would increase their serotonin surge, so that they can actually benefit from that little snack and sleep. So avoid sugars, avoid ice cream in the evening if you want them to sleep. It's important to notice that delirium is really a syndrome. We're not saying this is pneumonia. This is caused by pneumonia, all right? This is the difference between delirium and the actual causes is if instead of saying heart attack, I'm always saying chest pain. People have chest pain until we find out what they have. And then we say it's a musculoskeletal pain, it's a heart attack, etc. So delirium is really what manifest out of the physiological changes or the pathophysiology of the disease. So keep that in mind. Now, as you know, we have the ICD-10, which is the new and improved coding system. In delirium, I'm going to mention that in another slide, but it's relevant now. Delirium and dementia in general, we're dealing with this as internists, geriatricians, family practitioners, MPs, but really we're basing our criterias and coding on the mental illness guidelines, the DSM-5. So what ends up happening is that we're seeing everything from a psychiatry point of view. And we end up like looking at this sometimes say, what? And you'll see what I mean when I go over some of the new codes. So first of all, if you're looking for the specific diagnosis of delirium code, it's F05, okay? When you know the cause, like you have a UTI, they have something, you're not saying delirium, NOS, not otherwise specified, which is F05.9. Luckily, our office does our coding for us. However, we have to know how to write it. You know, if you write delirium NOS, it should be different than delirium. Now in ICD-9, we had acute delirium, we had subacute delirium, we had Alzheimer's with delirium, we had vascular dementia with delirium. We actually regressed with ICD-10 to the point that there's actually a code, R41.0, which is for disorientation, that covers both delirium and sundowning and dementia. So when you do that code, it means like I'm seeing a dementia patient and they're disoriented, and I can use that code. As you know, clinically it doesn't make a lot of sense, but there's a code for it. Anyway, I just wanted you to see what's out there. If you pick one or two for the ones you commonly use, you should be fine. However, this talk really is going to be different 3-4 years from now, because metabolic encephalopathy. How many of you have seen that on discharge summaries? A lot, right? It happens to be actually more accurate. Remember we said the syndrome, the result of something else? Well, the something else is metabolic encephalopathy. However, that is still caused by something else. So this is closer to the cause than delirium is. In other words, metabolic encephalopathy is delirium, but more specifically stated. So if you want to use a code, this is a better code, G93.41. I'm sure you all were dying to know that. Now the downside. Remember we said dementia and delirium can happen together? Well, ICD-10 doesn't have great options with metabolic encephalopathy. When you want to be more specific and use that code, you can't combine it with dementia unless you put a separate code for dementia. So if you're going to do dementia with delirium, write your specific dementia, whatever it is, as a code, and then delirium. So that's the reason you see this in discharge summaries. There's also a little other reason here. It pays better at the hospital level. Okay, so your case mix and your DRG is higher. And I want to do this backwards, but this is how it came out. All right, any of you know where this is? Other than Sarah? Because I showed you that one.
I know, that's why I know.
I'll give you a chance after everybody quits. Well, I'll give you a clue. There's a flag.
There you go. There you go.
Larry Guy, what did you say, Larry? Turkey. All right, yeah. This is called the German Fountain in Istanbul, near the Blue Mosque. I had breakfast there and took that picture. Anyway, back to business. So this is a facsimile of an actual case. You know, I simplified it a little bit, but this is an actual case that some of you will recognize, but because some of you are still taking care of that patient. So this is a 94-ish-year-old white male with peripheral artery disease, coronary artery disease, stage 3 kidney disease, anemia with chronic kidney disease, diastolic congestive heart failure, acute and chronic, and I think history of TIAs. So what does this, without knowing anything else about this patient, do you think this person has vasculopathy of any kind? A little bit, right? So this is, I mean, if he was obese, this was our syndrome X. You know, if he had a little diabetes and obese, we used to call those patients, I mean, having everything, basically. So this person has a setup for stroke, TIAs, anything vascular. Now, is the anemia important in any kind of circulatory issues of the brain? Right, so it's not enough to get blood, it's also enough, it needs to get oxygen, you have to have the right number of red blood cells. And I mention that because everybody else outside of geriatrics looks at anemia as something you should leave alone. You know, we don't transfuse anymore until they're like 5-ish. You know, they may get IV iron once in a while, but that's it. So it's really, outside of geriatric, people leave anemia alone because there's a lot of complications from treating it in younger people. And usually, you know, if it's chronic anemia, you can't fix. If it's acute anemia, it reverses. They consider symptomatic. The things that are not the geriatric symptoms, like you're tired and you're confused and you have delirium. Usually symptomatic means you're orthostatic, you're dizzy, you're having chest pain, that kind of thing in a younger population. But anyway, so he develops a confused state after hospitalization. And you know, when we reviewed his case, he was initially lucid, and then he got very confused. And once he started getting confused, he started fluctuating. So it would be good 1 minute and not very good the other minute. He was resisting care, doesn't let people give him a shower. He was resisting everything the staff were doing for him. So does he need a sudden change in cognition? He does. He's restless. He has the other symptoms as well. Now, he's also had recent weight gain. Remember we said he has congestive heart failure? Mm-hmm. So for delirium, was dehydration a risk factor? Yes. So a congestive heart failure patient had weight gain, and then you increase his diuretics, and then you check his labs. His creatinine went from 1.6 to 2.7. His sodium went from 147 to 155. Right? So this is pre-renal azotemia. If he meets the other diagnostic criteria, which we're not going to get into now, but it could be either getting dehydrated or dehydrated. Okay, but he has that disease process of congestive heart failure. And he's not satting great. Now his hemoglobin was 8.5. And look at the creatinine and hemoglobin. So this is anemia with renal disease. Is that anemia treatable?
Yes.
Right. So we could treat it with something like Procred, Epogen, Aranesp, colony-stimulating factors, right? It's very expensive, and the facility is paying for it because it's skilled. Just keep that in mind. Now, anybody noticed something here? The platelet is low at 88.
Yeah, but it's hypervolemic.
Well, if he was hemoconcentrated, so when the sodium goes up, because his volume is low in the blood vessels. Same thing happens with hemoglobin, platelet, WBC. If you want to look for hemoconcentration, then we should see an increase rather than decrease.
Right. No, hypervolemic, too much fluid on board.
If he was, then why would he have high sodium and high creatinine? His kidney is showing us that he's drying up. Okay? His sodium is showing us that he's drying up. So, and clinically, you know, his lungs were not filled with fluid. He did have third spacing, but not in his lungs. UA negative. So diagnosis. We would have said acute delirium, but we're going to use metabolic encephalopathy, right? You do want to get paid. So can we just say he has delirium and forget about it, or can we diagnose him with other things? Now, what are the chances that somebody who has TIAs, AFib, PAD, CAD, chronic kidney disease, might have cerebrovascular disease and have dementia to go with that, which is vascular dementia? For that to be the case, we have to prove that this thing is not all sudden. We have to trace back some of his confusion to months and years back for us to say that. And we could, based on the history we obtained from the family, and just knowing that case, he wasn't perfect until that day. Okay, he had cognitive issues to begin with that caused, cognitive issues at baseline. So now you have vascular dementia patient with acute delirium from metabolic encephalopathy. Now keep in mind that if we hadn't done a CAT scan to prove that he had a stroke, if his historical history, didn't have a history of stroke or TIA, proven history, then we can't, by DSM-5, we can't diagnose him with vascular dementia. It's very restrictive that way still. Okay? It's more lax in best practice standards, like the British Medical Journal, when they review vascular dementia that I looked at just in preparation for this lecture, they do not require, they say if you have extensive disease on the CAT scan, like what we see with white matter changes, then that can kind of substitute for stroke. And you can call that vascular dementia if you have cognitive impairment, stepwise drop in cognition, etc.
So is that any atrophy of the brain there you could consider vascular, or?
Well, atrophy is something different. So what I'm talking about is white matter changes which indicate small vessel disease on the CAT scan or the MRI. So what you see is that they actually, you loosen matter, not on the gray matter, not on the top where it would look like atrophy, but would be inside the brain, okay? And it's actually mentioned in reports as diffuse white matter changes consistent with small vessel disease. Now, if you have small vessel disease in the brain that's affecting a huge amount of the brain, okay, and it's causing dementia, is this vascular dementia or Alzheimer's dementia? If you go by the old, very strict neurology-based rules, they still can't make themselves say it's vascular dementia until you have proof of an incident or a history of cerebrovascular accident. Now, remember what I said about the exception, the asterisk, the suddenness? What if somebody develops vascular dementia? How would they develop it? Like the traditional way. You get a stroke, you get vascular dementia. Usually it's within 3 months of the stroke that you can diagnose vascular dementia. So it's not that long term. I mean, that 3 months, initially you might have a little delirium, but as soon as the delirium fades, you can literally diagnose dementia if you're at some level of stability. Now, when you get a stroke, is that sudden or insidious? Sudden. Does that sound like delirium?
Yes.
Right, so you could get confused between post-stroke vascular dementia and delirium, theoretically, okay? It's very hard to distinguish the first days of a stroke patient because guess what happens when you get a stroke? You got a lot of things going on other than the stroke, okay? You get immobility, you get pain, you may get aspiration from dysphagia, you get depression, adjustment disorder, new environments. So all the risk factors for delirium are there. But I just wanted to mention that so you know that this is not a hard rule, and there are exceptions to it, and vascular dementia is one of them. Now, the other thing I got to mention about vascular dementia is that the stepwise decline. So Alzheimer's dementia is a linear progressive decline. Vascular dementia is drop, stabilize, like walking down the stairs of dementia. Okay? You have a sudden drop, you stabilize, you have a new baseline. Sudden drop, stabilize, new baseline. Sudden drop, stabilize, new baseline. So when you have vascular dementia patients that suddenly change and you can't find a reason, okay? You didn't do any meds, they don't have an infection, the labs look great, nothing else happened, but you know they have vascular dementia and they have all these risk factors for recurrence of stroke. You actually should suspect a new stroke or a new event. And if they're 95 and you don't want to put them through an MRI, you are okay to diagnose it clinically that this is actually a cerebrovascular event without focal weakness because I can't find anything else. All right, so we went through that. The hour-to-hour fluctuation in our case was, of course, more consistent with delirium, not vascular dementia, right? And we mentioned that, so in vascular dementia, you don't find the cause. So management. Just like wound care, like when we have a wound, when we say, okay, let's manage the wound. Here we have delirium, let's manage the delirium. What do we do with wounds? We say, whatever we did for prevention of the wound, that either we forgot or we used but didn't work, we're going to continue during the treatment phase, right? You have to, because otherwise that wound will never heal. Same thing with delirium. So you know the risk factors. You know the things that make delirium worse. Sleep disturbance, isolation, disorientation, the fact that they have a new environment, that they don't have anything familiar around them, the noise level, the nighttime lights that don't let them sleep, all immobility, restraints, a Foley catheter that we put in because we don't want them to run to the bathroom, all of those things. In fact, Foley catheters are an independent risk factor, but even when you don't get an infection. So you got to prevent all of that stuff. So you got to, for example, now they have delirium. They're very confused. What do we do first? We stop therapy. Is that appropriate? The answer is no. And then you come to me and say, well, what do you mean? They can't follow instructions. Say, turn right, hold the walker, turn, stop, keep the walker in front of you. Don't put it on your right hand and leave it and walk. They can't do any of that. So why would we do therapy? You can't do OT because it requires a lot of instructions and following. It needs some cognitive ability. But you can do PT, which is more mechanical. You could have them get up and walk. You hold them and walk. PT can still do that. So it's important I mention that because part of the issue with delirium is the immobilization. So when they're immobile in a jerry chair, that actually if they didn't have delirium, they would develop it. So why would we do it in a delirium case? All right. So the other thing is really to begin with, you have to set the right expectations. So when you have a delirium case, if you go in and you don't mention to the family or staff what you expect, like this thing can last 2 months. It's normal for them to fluctuate from hour to hour, so the family is not freaking out at 1 in the morning, wanting them to go to the ER, which is yet another environment. And guess what they get in ERs? Adamant. And they come back perfect for 30 minutes. And then what? So you set the expectation that if staff need to be on board so they can educate the families, that this is going to last up to 2 months. It's going to fluctuate. We're going to work at the root causes and treat them one by one. And we have to set our expectations and not demand something from that patient that they cannot give us. Okay? Because if we set the expectation so high, that we're fighting to get there, we're going to hurt that patient by trying too hard. Of course, I mentioned the Haldol thing. We can say without doubt that any psychotropic medication, anything, whether it's hypnotic, benzodiazepines, antipsychotics, anything you, and even something like trazodone, anything you give to that patient with delirium that affects their brain does one thing. It may do more than one thing, but the one thing that they all do is make that patient more confused. Now, the new nurses here, we used to call these meds minor tranquilizers for the benzodiazepines. That was the category. For the antipsychotics, we used to call them major tranquilizers. Now, we use the word tranquilizers when we're talking about horses. Okay, so we have two huge drug categories that have the word tranquilizer in their description that are used for delirium cases erroneously. Okay, and then you have the hypnotics. Now, of course, not all psychoactive drugs are psychotropics. Things like Imodium. You know, how many times do we get a call saying, "Oh, somebody has diarrhea. Can I have an Imodium?" We removed that from the standing orders. We made it less liberal to use Imodium, and we educate around it. The reason is Imodium is an anticholinergic. You might as well give them Atarax or Benadryl. So there are drugs that are ditropan. Anything that affects the anticholinergic pathway will affect the brain and will cause delirium if they don't have it. And how many times do we get a patient from the hospital saying, patient has metabolic encephalopathy, all workup is negative. And they come in and there's a Versed ordered that's for irritable bladder and it's anticholinergic. I'm like, okay. That's like saying somebody is on Fosamax and they haven't eaten for 10 days. We wonder why. We'll figure it out one day. So there are causes beyond what affects the brain primarily that affects the brain. So medications are actually a big thing here. All right, now the one thing that we have to pause each time, and I really pause each time and ask the questions. When, in this particular case, the first time I heard he was agitated, it was around shower. And so the question to ask is, the person has delirium and they're agitated. And again, a shower. It's important not to push the routine on a delirium patient. It's important not to push it on any dementia patient who's agitated. But in delirium cases, they're like the ICU of dementia, basically. They're the crisis case of dementia. So, do they need a shower? And if they need a shower, do they need it in the evening when they're already sundowning on top of the delirium? Okay. Now, you know the common answer that I get is that, you know, we divide them based on the shifts, and the evening CNAs need to do some of them, otherwise the morning CNAs will have too much to do. This is true for everybody else, but not the delirium case, and not the dementia case on antipsychotics already. So that's something that's like, you can't do. It's almost like skipping antibiotics in a pneumonia case. We just can't do it. Doesn't matter how many people we inconvenience, we can't do it. The other thing, remember we said the sleep cycle? How many delirium cases do you see that you have vital signs done in the evening? A lot. How many people do you see that are resisting meds, but they're getting an evening med? Lipitor or something. Now, ideally you should give Lipitor at night, but it's not a disaster if you gave it at noon. The only thing you can't give at noon is a hypnotic. And we're not using it in this case anyway. So you could move things around. Okay, you could switch a low pressor to a long acting, give it in the morning. We could do a lot with medication timing. And we could have an order from the doctor that says no vital signs when patient is asleep. That covers you as nurses, But you have to have an order because then the surveyors come in and they might actually go by the book and say, okay, why aren't you following your own protocol of Q-shift vital signs? But that's another story. So, noise pollution. It's a huge deal. Okay, noise pollution. It's very hard for people who work in a facility to actually not talk. You know, especially in the evening, like people will try to pass the time somehow, but there's a lot of noise. There's a lot of noise from other residents. There's a lot of lights in the hallway. Like in places like Dorgan Pine, we actually removed every other light in the hallway so that we have less light in the hallway. The doors are always open and there's noise going in. Okay. What's the first thing we do with delirium cases? We take them and we put them in the nurse's station, which is the loudest, which has the most lights, which has a beautiful restrictive jerry chairs. So we got to do something else with delirium. If we did something else during the day, we gave them the right meal and the right time, they can go to bed at some point. If we keep trying every night, they will. If we keep trying, but the nighttime can't be the only people doing it in the morning. Just lets them sleep at 1 o'clock. So, you know, keeping them active during the day, looking at the diet. If they are up all night, we got to restructure the activity level. I mean, if we give up on reversing the sleep cycle, and sometimes I do use sleeping meds, but if you're going to do that, you got to put a time. You're going to use it for a certain amount of time and a certain. You never use trazodone PRN for an agitated patient. You just say, okay, at HS at that time, and stick with it. Because if you, on top of giving them a nap, you give them trazodone at 2 in the afternoon, you're already kind of shooting yourselves in the foot. One thing that doesn't get mentioned a lot is in the bottom where you can't see here, is the reducing negative interactions. I find that to be common when I visit and families are there. They're constantly correcting them, trying to train them to remember, and quizzing them, basically. You know, correcting, quizzing, correcting, quizzing. And you have to sit back, you know, basically have the conversation that, number one, it's agitating, not just to us, but to the patient. And so, you know, if you're already confused and your wife is telling you, well, you should remember this because I just told you 5 minutes ago, and this is what this is. The least it does is making someone feel stupid if they're aware enough. So if you feel bad, you're not going to be, you know, getting better anytime soon. You're going to feel sad and depressed, and it will add to the issue. So we try to tell the families, like, please don't have that expectation. And plus, you may have the conversation, you have to repeat it 5 minutes later. It's going to aggravate you as well as your loved one. And of course, you know, some of our own staff sometimes fall into that trap of saying, you know, just like I showed you 5 minutes ago, that sentence doesn't serve any purpose. They don't remember 5 minutes ago. So you're basically just rubbing it in that you remember and they can't. Okay. New pain sources. Catheterization is one of them. Okay. Catheterization is traumatizing. The other thing is sticking patients for labs. They just had labs yesterday at the hospital. I don't need new labs. Even if the hospital discharge summary said, let's get some labs. They were in the ICU. They used to get labs every day. But now they don't need it. You know, you have a relative good handle on their labs. You don't have to do it every day. It hurts, especially when they don't know what they're doing. You know, like the resident doesn't know why you're doing it. And they can't even comprehend the reasons. Medication changes. If you got to do something, don't overdo it. Like if you're fixing blood pressure medications, don't do it all at once. Things like prednisone addition, etc., that has more effects on the brain as well. Falls and related pain. Remember what we said about keeping them active. If you don't keep them active, then they're going to start falling. If they fall, they add to their delirium because now they have pain. If you treat the pain with pain meds, now you have another factor affecting the delirium. Poor sleep, we talked about it. Treating the anemia, and this, you know, addressing all reversible causes here. Now, if they're low on B12 and folate, you treat that. Now, how many times did I treat B12 and saw a miraculous recovery? Never. But I do it, right? Because it's reversible. You treat the anemia, that actually has more impact because you get better oxygenation. In this case, we had to ignore the weight gain, and we reacted to the fact that the person was getting dehydrated. Okay? Adding house supplements early. Now, I know in general, in regular cases, we don't add house supplements. We want them to take a snack. But in these cases, you're already fighting them with the meal, you're fighting them for the med, you're fighting them for the shower, and they're not eating very well. You go to the path of least resistance to get them quick intake to prevent dehydration. And also nutritional issues are a factor independently. Stop all unnecessary meds, okay? In this case, we also discussed prognosis and palliative care. A 94-year-old with vasculopathy who has delirium and other acute illness and hard to control congestive heart failure, we would be missing something if we don't include that in the conversation. Now, that doesn't mean we don't treat the reversible causes. 2 weeks later, the cognition fluctuations and agitation improved. Okay. Now, like I said, delirium can last hours to up to 2 months. Okay. After 2 months, you got to look for another diagnosis, unless it's medication related, where they would get recurrence. The labs improved. The anemia corrected, so his hemoglobin was like 10.5. And the SATs were well, but he was dyspneic. He looked like he can't breathe very well, but his SATs were well. And on exam, he had anasarca. Now, anasarca means swelling everywhere, basically. He speaks Latin. He's sleepy and withdrawn, but arousable. Does that sound familiar? Remember the hypoactive delirium? That same patient could still have delirium. We could misdiagnose the fact that it's resolved because everything else got better. But he's withdrawn, and that withdrawn is new to him. That's not his normal. So that means he still has delirium. Now he has, if he has withdrawn and agitated in the same day within 24 hours, what is that? It's mixed, okay? In this case, it's not happening within 24 hours. He went from hyperactive delirium to hypoactive delirium. He still has delirium, okay? Now, what about that thrombocytopenia we talked about? Platelet of 88.
Was he on heparin?
Not on heparin. It was, well, first I'll add that he had ecchymosis on his belly and back, okay? So a sign that he's bleeding.
Or was he in the hospital first, and they gave him his heparin because he was immobile?
It's new.
Okay, but he's also on aspirin.
He's on aspirin, he's on omeprazole.
Yeah.
Omeprazole that treats acid, guess what it does to platelets? Right? So that delirium case can get more complicated by the hour if you keep at it in geriatrics, right? So we stopped his omeprazole and stopped his aspirin. Now with his history of vasculopathy, is that risky? Yeah. He might get a stroke. However, for now, I want him to live. All right. Now, for those of you who hasn't got their flu shot, I hate needles. I go through this ritual every year. Okay? And I'm getting mine next week on Tuesday. I did weasel out of it. I weaseled out of it on Tuesday and Thursday, but I'll get it. Yeah, just remember with the flu shot, you get 30% reaction in the best of seasons in your elderly residents. You get more than 70% response in our cases, in our blood, which means our vaccination protects them. Their vaccination does very little. That's why we vaccinate. It's not because we will get sick. And on that note, if you have any questions, otherwise you're free to lunch. Mingle so you can win the stethoscope. Any questions? Oh, Larry.
Because the different types of dementia, like capacity, vascular, in Alzheimer's? Is it any more prevalent with delirium
Good.
episode like?
Good question. You would think, for example, in vascular dementia, if somebody has hypotension issues, they would be more at risk than a regular Alzheimer's patient. The data doesn't differentiate, unfortunately. It's one of those things, you saw the wide range, 16 to 50, which means in some studies they looked at 16%. Now in those studies, how many of them had different dementias? We don't know. Yes, sir.
So when I worked with the health program, they taught us that some ridiculous number, like 80% of people that get delirium for the first time can pass within 2 years from that episode. Typically because of the age of the people that were getting delirium. And the biggest thing that we did walking around was entertain these people. Because if you're just laying in a bed, which I mean, it works in our nursing homes too, if you're just laying in a bed and you're bored, you're gonna lose track of time. But even elderly people can do like word search puzzles, even if they're just playing or coloring.
Right.
So to incorporate that in our actual
Right.
day-to-day routines with them is big.
And what you're doing there is both mentally stimulating and physically, because they're not sitting by themselves in a jerry chair. So you're kind of hitting 2 or 3 things at the same time.
Jafar, I want them to apologize for that. I want everybody to understand about delirium because I keep going to presentation after presentation after presentation about delirium. I do a presentation myself at Columbia University at the Social Studies School about delirium. And it feels good. You talk about, we talk about omeprazole, benzodiazepine, folic antidepressants, and at the end of the presentation, most of us leave with the idea that we're doing a radically poor job with delirium. The reality is this: you said 50% can be prevented. Here we go. 50% cannot.
Right?
And that's the ones that are going to heal us 24 hours a day, trying to help them. The nurses are scared. They run away, they fall, they have those problems. And we feel like we're not doing a good job. Guys, you're doing a great job. I think I'm doing a great job. Jafar is doing a great job. It's a disease or a syndrome, whatever you call it, that cannot be fixed a lot of times, at least 50% if you look at the statistics. And we're gonna all have those situations that's gonna drive us crazy from acute kidney disease, hydration, heart failure. Those people are at the end of their lives, and maybe hospice and comfort measures should be the approach rather than delirium management. That's my take on it. Because again, delirium is such a presented problem in all those geriatric conferences, to the point that it feels me like I'm either incompetent or I'm too enthusiastic about it.
Now,
That's my take on it.
thanks for that. I mean, this is an element that's important to discuss. Now, what I would suggest is the HELP program, which is designed to deal with and prevent, actually showed that the incidence and then resolution and the rate of falls, rate of readmissions, all of those factors did improve, even though you're not doing one thing to resolve all the cases. You're doing like 10 or 12 things for everybody, regardless of their type of delirium and the onset. And it ends up being a marathon for every case, but I think it has positive, even when we're not successful in one case. This is like when we have a very difficult dementia patient. We may not succeed in meeting all their needs, but in the process of trying, we actually improve the culture of the facility. Because if they can try to deal with the most difficult case, and they're willing to, believe me, they'll do a much better job on your less challenging cases. So I mean, while it's like accepting that you may fail, but yet there's so much to do that we're constantly just focusing on what we can do, not on what the patient can, basically the outcomes that the patient may have or may not. But that's my angle. I mean, I sympathize with that thought. That's why in that case, I basically told the family, I said, this is my Hail Mary. We're going to give him the epogen. We're going to do all this. If it doesn't work, his restlessness, because he's not moving that much, it could be pain. So we're gonna start treating the pain more aggressively with narcotics. And that's where we are at. We're gonna make a decision probably by next week if he's not improving, or if there's a sudden drop.
We had a conversation.
You did, see? I mean, we left it like that on Tuesday, and 3 days later, that 94-year-old that we spent 3 weeks trying to fix, he's gonna be on palliative care. But it doesn't mean we did anything, we should have, I mean, the process of trying, that case, number one, was the first education the staff had on delirium in months. So it worked out. Dr. Brown.
Do you want to talk at all about the duration of delirium? I read something once that said the average duration was 6 months. You used 2 months. Average means they're going to go a lot longer, yet nursing often will, or family will think it's going to get better tomorrow if you treat them. How do you look at that?
Well, we used to, remember we said we have acute and subacute delirium. I was taught in the fellowship that if you do anything more than 2 months, you got to consider subacute or recurrent. Like you're given for example, if somebody's getting narcotics and the dose is adjusting, etc., and they develop delirium every time you adjust the dose, or every time they get a PRN, then this is a recurrent delirium that's never going to end. And ICD-10 actually now has a code for dementia caused by medications. So when a delirium, which starts as delirium from medication, lasts forever, then that's dementia. But you have a cause. You have a cause which is medication. We also have with the alcoholic dementia now, there's a code for ongoing dependence. So if you have ongoing alcohol intake that's contributing to your confusion, it's a type of alcoholic dementia. So we kind of that part is really great about the ICD-10. But now the chronic, the longer lasting delirium now has we can classify it. We can say, look, this is not going to go away. This person always drinks, or we're going to always be using the narcotics, or they're always falling and hurting themselves. These are the things that are not going to go away. They're always going to be confused, and chronicity equals dementia. To me, chronicity doesn't equal delirium. And so the 6 months probably was the subacute end from 2 to 6, that we could fit it in that, but we don't have a code for it anymore. So I don't know what to do with that except to link it to one of the reversible dementias that are irreversible because you can't take away the offending factor. I hope that's not too confusing.
In this particular case study, did the epogen that you gave that to the patient?
Yeah.
And that brought his hemoglobin up to 10 in 2 weeks' time?
Yeah.
Now, is that very expensive? Because I always notice they put geriatric patients on the iron, which is really problematic in its own right.
Right. It is very expensive. Now, in fairness, this is how I do it. We try to be very frugal with everything else. And in geriatrics, actually, cost effectiveness usually means better care. So we're not being frugal because we like the facility. We're being frugal because, in general, that's a good thing to do for geriatric cases. So our pharmacy bill is very low. So we could afford, for the sake of meeting our mission, to treat this patient. I only gave him 3 doses of 10,000 international units. So that's going to cost us about around 1,000 or less. Okay, but 1,000 or less that happens every 3 to 4 months, 2 to 3 months, is manageable when we keep our pharmacy bill low. And if they're in long-term care, Part D pays for it. In his case, he's anemia with chronic disease, so the fact that he had creatinine high, that qualifies him, but they will require you to do iron studies to go to for the prior authorization.
The prior authorization is very difficult outside of SNF.
Well, we don't need it in SNF, but outside of SNF, not only is it difficult, but they will make you renew it. So they don't say, well, we established the diagnosis, they have kidney disease, they make you renew it every time. So that's why as outpatient now, instead of putting somebody on a steady dose, they put them on a PRN dose because they find that that's more meeting the system. So they do blood work every 2 weeks, and they say if your hemoglobin drops below 10, you get a shot. And then they give them a huge shot. And they cover it that way. And usually it goes through nephrology or hematology offices. Yes?
I also wanted to point out that there is a form of depression that can present as a dementia as well. And so I'm kind of thinking about that when you're trying to decide and determine if it's a delirium or a dementia or
Absolutely.
for the elderly that can play a part.
Absolutely. I mean, depression is a whole other story, but you have dementia with depression, you have pseudo-dementia from depression, you have the hyperactive delirium that can look like depression, so you actually have to differentiate the two. So yeah, this is part and parcel of what we look at. Any other questions? Going once? All right. I'll see you after lunch. Our next talk is
At 1:45.
1:45. So mingle and then lunch.
Yeah, bring your tickets to lunch.
Maybe less than 15 minutes.
There you go.